Well, hi everyone. As she said, I'm Elizabeth Gilbert. I go by Lizzie, so please feel free to call me Lizzie if you have questions or anything like that. I am a master's prepared nurse. I'm an advanced practice nurse, so I'm a provider at the hospital, and I run our stroke program. I specialize in neurology and particularly stroke care, a little bit of seizure, I do some diabetes. So I am here today. This is National Stroke Awareness Month, hence my t-shirt that I have on today. And so I just want to welcome you all and thank you for being here today. And like I said, braving the rain to come and see me. So quickly, just a few facts. Every 40 seconds, a person is suffering from stroke. And on average, about 800,000 Americans are having a stroke each year. Every 4 minutes, a person actually dies from a stroke. And really what we find, I find that very interesting because you're talking globally when you're looking at that number of 4 minutes. Most people truly do not die from a stroke. Yes, does it happen? Of course it does, right? Especially our hemorrhagic strokes, which we'll talk about. What we find is that most people are left with severe deficits from stroke. And so it's the mortality from the deficits, not being able to get around. You know, they develop sores and things like that happen and occur. And so that is the thing that you really want to watch with people who have had a stroke, and why I'm here today, because the goal is to try to prevent, right? You want to try to prevent the long-term disability that stroke patients suffer from. All right, so it's the 5th leading cause of death in America, as well as here in the state of Ohio. We moved from the 4th leading cause to the 5th leading cause, probably about 5-6 years ago now, which I was really proud of that. And I hope we'll someday move to the 6th leading cause here in Ohio if we keep working on things like this, getting out into community and making sure that, you know, everyone knows their numbers and is doing what they need to do for stroke prevention. But it is, like I said, it is the #1 leading cause of long-term disability. So that is why we learn about stroke. So what is a stroke? So it really is when you have interruption of blood supply to an area of the brain. Typically it's some blockage or you could have a hemorrhage, okay? So that is where as blood supply stops, brain cells start to die within minutes. So the two types, ischemic, caused by a blood clot blocking an artery within the brain. So you're not getting oxygenated blood flow to that area of the brain. Then we have what's called a hemorrhagic stroke, where you have a rupture of a vessel within the brain itself. Sometimes it's at the surface with the subarachnoid. A lot of times that comes from traumas like falls and things like that too. But within the brain tissue itself, as you can see here, the picture there, that's a bleed, more on the surface there. But usually it's an aneurysm that ruptures. And most people don't even know that they have aneurysms. We find them typically on happenstance, us neuro providers. You know, you may have symptoms or things like that if it starts to get bigger or enlarge, causing headaches and some other symptoms that look like stroke before it actually ruptures. And so if you have any of those symptoms, you definitely want to go to the emergency room. If it's small and it's contained, what we do is we monitor, you know, aneurysms and things like that within the brain. We don't want to put people at risk for infection going into the brain to fix that artery unless we absolutely have to, because there's risks, right, when you do surgeries and procedures. And so we'll monitor those patients. You'll see a neurologist regularly. You maybe every 6 months to a year, you will get annual MRIs and CT scans of the brain to be sure that that aneurysm is not growing. So those are just some of the things that we do to monitor these patients. If it is a large aneurysm, there are procedures we can do called coiling, clipping. We can do embolization and things like that. And what that'll do is it'll prevent that aneurysm from rupturing. Any of those procedures. There are different procedures, but they all have the same outcome, which is prevention of aneurysm rupture. So we can fix that ahead of time if we can catch it before the hemorrhagic stroke occurs. Majority of our strokes are ischemic strokes, or 87%, and the remaining is our bleeds. So a TIA. I like to talk about TIA. For neurology folks like myself, we like to call it a warning stroke. A Lay people in the community call them mini strokes. Have you guys heard of mini strokes before? So that is TIA stands for transient ischemic attack. So what makes this different is you just have a temporary blockage of blood flow. It's not a permanent occlusion like what happens in stroke. So you get these temporary stroke symptoms that resolve within 5 minutes to 30 minutes. Textbooks will say within an hour is what we train healthcare professionals, that TIAs can resolve out to an hour. But I find in the emergency room when I'm treating patients, usually their symptoms resolve within 5 to 15 minutes or so. And so it's transient. So I say that these people right now are blessed, okay? But it is a warning sign, and that's why we call it a warning stroke in neurology world. So what that means is that if you had enough of the risk factors or something going on in your body enough to cause you to have a transient ischemic attack, then that means you have damage of your vessels and arteries and things like that to now cause a full-blown stroke, which is what I call a brain attack. So you want to be sure that you're looking at managing your risk factors. Okay, and so you see 5% have stroke in the next 2 days and 25% have another event within 3 months. So that is why we call it warning stroke. So what do we do for these patients? Well, when you come into the hospital with a TIA, we still do a full stroke workup. The difference is that when we do an MRI on this patient, it doesn't show a stroke. But when they came in, they had clear-cut stroke symptoms. We can find no other reason for the symptoms that they presented with. Right? So we look at the risk factors that patients have, and we want to educate towards those risk factors. We want to be sure that they're on the proper medications when they leave out of the hospital to manage those chronic conditions that might be contributing to potential stroke and the TIA. And we want to be sure that we make sure that they're following up with their proper providers, seeing their primary care provider, connecting them with a neurologist so that we can be sure that the chronic condition is managed. And the goal is not to have the full-blown brain infarction or stroke. That is the goal with a TIA. So I like to tell you guys this term in case you hear it, cryptogenic stroke, because we use it in the hospitals. These are patients that have had a stroke, but we cannot determine the reason why, at least not right away. When we go through the typical risk factors, which we'll go into a little bit later in the presentation, these patients don't have the typical risk factors that cause a stroke. So there are other things that can cause stroke that aren't in the typical list of risk factors that we can assess right up front in our patients. What you find is 25% of strokes in people age under 70, we can't find the reason. And 40% of strokes in the age under 45. But what research has shown us, and even my personal experience as a stroke provider, is that we find these patients are in paroxysmal atrial fibrillation. Our older folks typically. Our younger folks typically have what we call patent foramen ovale. That is a heart condition. When we're born, guys, our heart, I call it the leaflets between, the atria and the ventricle. They're open. And as we get older, those leaflets between those chambers close. Well, there's a segment of the population where those leaflets never close between the chambers. It's not lethal. Most people don't know it until, unfortunately, they've had clots in the body or a stroke. And so because of that, same thing with atrial fibrillation, when your atria they're supposed to close nice and pretty and hard like this and pump blood one way through the heart. Well, if you have fibrillation, they kind of do a thing like this, okay? And so when you get that, you don't get that nice forward blood flow. And so blood sometimes can be stagnant at the base of the atria. And so when blood doesn't move, it coagulates or forms clots. And then something happens where that person then gets scared, they get into an argument. I've seen it with couples who are having sexual relations, things like that gets the heart real revved up and the clot will shoot off. And then it will cause a stroke to happen. So that's typically what we find in this patient population. Because people can go in and out of atrial fibrillation. Some people are in it constantly, but most people go in and out of that arrhythmia. And so you don't know that you have it unless you can feel the symptoms. Some people can feel that heart race and they're like, something's wrong, and they can tell the doctor, but most people don't feel, or a small segment of the population, I should say, don't feel that racing of the heart and, the increased rhythm and things like that. And so you have to manage that. What we do with these patients is we send these patients home with a 2-week event monitor, a heart monitor, and that's for insurance purposes. If we have to be good stewards of our patients' money and finances as much as their health, guys, and we do think about that and consider that for you all. But if we don't find AFib, guys, within that 2-week event monitor, then we can do what's called an implantable loop recorder. And that's just a little monitor about this size that just goes under the skin. They do it right there in the doctor's office, right over the heart. And it can record out to a year or longer. Because what research has shown us in stroke world is that it can take on average about 84 days for a person to flip into a bout of atrial fibrillation. So if we send them home on a 2-week event monitor, right, evidence shows we're probably not going to catch it. So they've invented something that can now monitor patients much longer, that's non-invasive, and the data go straight to the cardiologist's office or the neurologist's office, and we can monitor the patient's heart rhythm. So it's really nice. And then it helps us with detecting that atrial fibrillation so that we can now get that patient on what we call an anticoagulant, which will help prevent blood clots from forming, as I discussed before. And so, atrial fibrillation. And so I just wanted you all to understand what is that. And so, an estimated 2 million people in the US have this condition. They did a trial and looked at patients with the pacemaker. So a lot of times we'll do a procedure called ablation on these patients to try to help the heart reset itself. But we can do a pacemaker if the rhythm is chronic and constant to try to help control that rate and rhythm so that you don't have that. These patients are 5 times more likely to have a stroke. And it's because of what I explained to you with the clot formation and things like that. So common reason of second stroke in patients. And so I already talked about how we can monitor the patients to help manage and detect if they have atrial fibrillation or not. And I didn't tell you guys, with the patent foramen ovale, I find that more so in the younger stroke population of patients who we cannot detect a cause otherwise. And we can see that when we do our echocardiogram, which is part of our stroke workup on every stroke patient through Premier. And so when we find that, then what we have to do then is bring in the cardiologist, guys, and they can actually do what's called a PFO closure. And so it's this little device, it looks like little cups like this, back to back. And they just put it right between the atria there, okay? And it closes off that leaflet, right? So now blood flow can flow one way, and we're no longer getting that stagnant blood at the base, okay, of the chambers. And so it helps with preventing the clots from forming and traveling. And so that's what we do for our PFO patients. So stroke prevalence increase in women. So women do have an increased risk for stroke, and I like for my women in the audience to know that, and it's for several different reasons. We find that women get less aggressive treatment. There's still not enough research out there about our bodies, right? How things affect us. They do a lot of research based off of men's bodies and men's health and men's systems, and we're very different. So we need more research around our health, and I believe we're starting to do more and more of that. Hormone therapy, younger women who are on birth control. We are very clear to talk to young women who are smokers. If they're smoking cigarettes, they cannot be on birth control. The hormone with the cigarette smoking, guys, is prime for clot formation, okay? And not just in the brain, but anywhere in the body. You're talking pulmonary emboli, AMI or heart attack, brain attack, stroke. You're talking blood clots in the legs, which we call DVTs. So that's just something that every woman who smokes, doctors, providers were like, nope, no hormone therapy for you. Also, older women, right? When we go through menopause and things like that, sometimes they want to put older women on hormone therapy as well increasing different risks of things. And so it has to be a really well-informed discussion, I feel, with women and their providers about hormone therapies. Make sure it's an informed decision, and make sure you ask all your questions, please, for yourselves. Gestational diabetes and gestational hypertension. So that is, diabetes during pregnancy is what that means, as well as high blood pressure during pregnancy. Again, those conditions put women at increased risk. One, for diabetes later on in life, or for a risk of hypertension later on in life, even after pregnancy. And those are two risk factors for stroke, diabetes and hypertension. Hypertension is the #1 risk factor for stroke. And so managing your blood pressure is the most single important thing you can do really for your body, right? Okay. So would you recognize the signs and symptoms of a stroke? So here's where we get to the down and dirty gritty that you want to know today, right? And so signs. The biggest piece here is that word sudden at the top. Because when you have a stroke, whether it's a clot that's blocking the blood flow or whether you have an aneurysm that ruptures, guys, it happens suddenly. That clot lodges in that artery all of a sudden. It's not this little slow thing that occurs. It's nope, that clot's there it is, I'm blocking the flow. When that aneurysm ruptures, it bursts. So these are symptoms that come on all of a sudden. You'll have a person who's talking to you and then right? All of a sudden, they can't talk. They can't get their words out. They're struggling to find what they want to say. And it is very frustrating because they know what they want to say, and they're just like, oh. They start doing word association to try to say, instead of cloud, they might say cotton, cotton, right? So things like that. And also, keep in mind, it's also the opposite of that. Sometimes they're talking fine, but they're not comprehending what you're saying all of a sudden. You ask them a question and they respond to you, and the answer makes absolutely no sense to the question you asked. That's a problem. So, weakness or paralysis on one side of the body or another, numbness or tingling on one side of the body or another. Typically, stroke symptoms happen on one side. It can happen on both depending on the area of the brain. We're not going to go that deep today, okay? But typically, if it's the right hemisphere of the brain, you get left-sided stroke symptoms. If it's the left hemisphere of the brain, you get right-sided stroke symptoms, okay? Double vision or trouble seeing out of one or both eyes. That could be a problem, especially if you have a stroke in the back of the brain. The occipital lobe controls our vision. It's back there. Confusion, and that's what I was talking about earlier, with not comprehending your questions or your discussion. Dizziness, difficulty in balance, and trouble with speech, which I already talked about. And dizziness is a big one because for us as providers in the hospital, man, doctors and nurses hate dizziness because it can be almost anything. Dizziness could be inner ear, dizziness could be stroke, dizziness could be heart. I've seen dizziness more with heart problems, especially syncope, where the blood pressure shifts when you stand up and sit down and you get dizzy. Medications, a lot of meds have dizziness as a side effect. Yeah, had a stroke alert yesterday, a lady who was already admitted, and poor thing, she just had the whole gamut of dizziness. She had already had a stroke. She had one in the occipital lobe or the back of the brain, and then she just worked with therapy. They dropped her blood pressure, so that didn't help, right? So, right? And then she's also started on a blood pressure med, a diuretic, that could cause dizziness. I said, okay, guys, what are we doing here? So, so I had to have some conversations to help everybody understand what are we doing to the brain, right? And our brain's trying to heal. And so, so those are the types of things that we do look at. Be FAST, though, is the acronym that I want you to know. When you leave here, if you remember nothing else, be FAST is what I want you to remember, right? So B, loss of balance. Are they dizzy? Do they have a headache? Remember, these are symptoms that come on all of a sudden. E is eyes. So do they have blurry vision? Do they have double vision? And remember with the dizziness too, that B, it could be vertigo, is the room spinning. Does it come with nausea and vomiting? Those are important to know. Have they lost vision in one or both eyes? Is it total loss of vision? Is it just a quadrant? Is it like a whole half of their visual field? Those are important to note. F is face. So you really want to have them smile. Okay? And I naturally have a crooked smile. And I tell all the nurses and doctors at work now, this is not facial droop. But you really want to see the same number of teeth on both sides of the mouth, right? And both should go up, the corners of your mouth. So you want to be sure you see that. If one side goes up, not the other. See that? That's a problem. And what you find is people who have facial palsy also have some dysarthria. They don't always have difficulty finding words, but usually sometimes their words aren't clear because this side of the mouth is kind of stuck in place. See how I sound different just from me not moving the left side of my face? I know, right? I play a good stroke patient, don't I? So yeah, A is arms. So you really want to have them hold their arms up. Is one dropping? Is one really heavy? Like one pops up so easy and the other one they're like, oh. They're struggling to get it up, right? Or if it's up and it falls or it drifts very slowly down. Like you can tell they just can't hold it up there. S is speech. So we talked about that already. Do they have a hard time getting their words out? Do they have all of a sudden garbled speech? Are they not comprehending what you're saying to them? And then T is the most important part, is time. Please call 911. Don't throw your loved one in the car and drive them. And literally, unless you live literally right next door. Please call 911. And I say that because EMS providers, they can activate the stroke alert before the patient arrives. What that does is it gets the whole stroke team on board and it gets them ready to go. And we're at the door waiting on that stroke patient to come in. Research has shown, and my personal data at the hospital shows, that these patients have the best outcomes. Compared to my patients that walk through the front door. So I really prefer EMS and 911 so that they can call the stroke alert before they arrive. It gets everybody on high alert. We hold the CT table because we know you're coming. We don't put another patient in there. We're not going to hold up that process. We want to be sure that we're getting that stroke patient through really quickly. So there we go. Call 911, please. And that's just, again, the be fast, just to remind you, because I want you to leave here with that. Okay. Did you know? And this is why I scream about please call 911. Less than, look, Janella, there you go. Less than half of all 911 calls were made for stroke within 1 hour of the symptom onset. And this is why I love coming out into the community and educating and talking with you guys, because when I started in this role 11 years ago, when I became an advanced practice provider, what I would hear a lot in the emergency room when I'm down treating the stroke patients coming in was, well, I had just a little tingling in my left arm, and I was like, oh, it'll be okay. I went and took a nap. Then I woke up and my whole left side was numb and tingling and I couldn't feel a thing, and now I can't move a thing. And now my stroke patient's crying and they're bawling because they're scared to death because now they feel trapped in their body, so to speak, right? And so that is why. Very different than heart attack, where, most people with a heart attack, they feel like they can't breathe. They feel like an elephant sitting on their chest. They have chest pain that's radiating and it hurts, and they have that impending doom feeling. Well, with stroke, believe it or not, even though the brain controls everything in the body, it has no nerve endings itself. It has neurons and things like that within. Have you ever seen videos, though, where, particularly people who are having epilepsy are having surgery and they're wide awake, and the doctor's all in their brain there just doing all kinds of stuff? So typically, stroke doesn't cause pain. So people feel these little nuanced symptoms and they just kind of ignore them. I'm going to tell you today that if numbness and tingling does not go away within 2 to 3 seconds, something's wrong. I need you to get to the emergency room. It could be stroke. It may be something else. There are other things that look like stroke and act like stroke, but they're still a problem, okay? So I want you to be aware of that. Because, when we fall asleep and lay on our arms and hands and things like that, our foot and leg, goes numb. But we all know that feeling, right? When that blood flow returns to that limb, we're like, ooh, within a few seconds, right? You got full sensation back and everything's all good. If that's not happening, like I said, 3 seconds, I need you guys to get seen. All right. Time is brain is our saying in stroke world, and this is why. For every minute's delay, the brain loses 1.9 million neurons. Those are brain cells, is what those are. 14 billion synapses, and I'm going to explain what all these are to you in a moment. 7.5 miles of myelinated fiber. If a stroke runs its full course, that's about 10 hours on average, the brain loses 1.2 billion neurons. 8.3 trillion synapses. Do you even know you had that much up in your brain? I say that to the nurses too, because they don't know they had that much either. Half of them say, Lizzie, I don't think I even have half that much. They like to tease themselves. And then 4,470 miles of myelinated fiber. You even think you have miles in your head, huh? But you do. And this is why it's so important for us to treat stroke, to get into the hospital really fast, to prevent that, because this is what causes the deficits in your body. So what are neurons? Neurons are nerve cells, right? So they send messages all over your body. They help you breathe, talk, move. They help the brain talk to the rest of the body. And synapses are places where the neurons connect with one another. And so that's how the neurons talk to each other. Then that's how we pass signals all throughout our body. So like right now, my brain's telling my hands to move. And so all of those things are working to help my hands move. And then myelinated fiber, that's a coating that's on that neuron, that's on that cell. And so what it does is, so this is a good analogy. I tell people it's like an electrical cord. So we all know there's that electrical current that's going from the source to my laptop, right? That's telling the laptop to turn on, to work, give it energy. Well, and then you see it's insulated. And so what does that insulation help do with that cord? Yeah, it keeps you from getting shocked. It keeps that signal running along the cord, right? It keeps the signal from jumping out and messing up that relay of signal. Well, guess what? That's exactly what the myelin fiber does in our brain with our neurons and on our axons. It actually helps keep that signal traveling in a nice, pretty flow from our brain to the area of the body that our brain's saying move or work. People who have multiple sclerosis, some of those peripheral or central nervous system disorders and autoimmune disorders like that, this is what happens is their myelinated fiber gets eaten away. That's why your multiple sclerosis patients, their brain's saying move right, but they actually go left and they can't control it. Or their brain's saying sit down, but they stand up. Okay, and of course it can get worse than that for them, but that's just a very rudimentary description of what they deal with, but that is because that signal is jumping all around because it doesn't have that coating to keep it moving right to the area that needs to move. Does that make sense? So myelinated fiber is extremely important for us. Okay. There we go. And that's what they look like. So up here in the corner, that is a neuron. That's a nerve cell. Aren't they cool looking? I think they're, oh no, I am a brain geek, guys, okay? And so look at that. And then this, guys, is between the two neurons. It's a synapse. And so chemicals actually talk to each other and transfer between the two axons or neurons, and this is the synapse. So this is how they talk to each other, right? And these are covered with myelin. So it helps that signal travel all the way down to where it needs to go. And so that's kind of how it works. So stroke is preventable, but we can also treat it. And so tenecteplase is now the new drug that all the hospitals are using. It's probably been around for, I think, going on 4 years now. And it's been around longer than that, but we used it for heart attack or AMI treatment years upon years ago. AMI really no longer uses that. They just go straight to cath lab now. Because again, we've just gotten better and better at how we treat people these days. And so with stroke though, this medication is an actual clot buster. We used to use another medication called Alteplase, but that one you had to hang over an hour. It was an IV drip and it just kind of took a long time. This one is an IV push medicine. The nurses push it in 5 seconds into the patient's, potential stroke patient's vein, and it works just the same. And so, yeah, it's a miracle drug when patients can get it, and it does what it needs to do. The caveat, guys, is it must be given within 4.5 hours of the onset of symptoms. And this is typically what we don't meet. Because what did I say a few slides ago? People don't come in. Right? They go lay back down. They go to sleep. By the time they wake up from a full nap and they get into the hospital, they have not met this window. It breaks my heart every time. Because it's like, oh, I wish they had just come in so I could give them this drug. Beyond the 4.5 hours goes outside of parameters and protocol, guys. We are an evidence-based practice facility. Most hospitals are. We're not going to run the risk of going outside of protocols, because that's what the research has shown us is safe. We have to always be safe with our patients. So I've only seen, I can still count on one hand the amount of times we've gone outside of protocol, and that was strictly to save a life. And we have 3 neurologists that have to agree to go outside of protocol. If one of those 3 don't agree, it does not happen. They have to all be on the same page and have a big shindig to say, we're going outside of parameters, but we got to do it to save this person's life. That happens very rarely. Like I said, I've been at Atrium Medical Center for 11 years as a provider. I think I've seen it 3 times. So we typically don't do it, is my point. So I really need you guys calling 911 for yourselves, your loved ones, whomever, and getting into the emergency room. The best thing about this drug is 30% more likely to have minimal or no disability at 3 months with it. The nurses love it. You know, because their hearts go out to these stroke patients. And when a patient comes in and they can't say a word, they can't get a word out. And then literally an hour later, they're talking. And they know what the patient wants and what they're thinking. And they're like, oh my gosh, this is wonderful. That's what this drug can do. Dissolve that blood clot that's in the brain, so that you can get that oxygenated blood flow back to the area, right, and reverse the stroke. Now, when neurons die, they do not regenerate. So that's the caveat. So that's why time is brain. That's why we got to have these time frames and parameters around when we want to get this treatment in. So if brain cells are already dead, they're going to be dead. There's nothing we can do about that. But the goal is to try to prevent any more from dying, right, in this cascade of a stroke. So that's what we want to prevent. We also can do what's called intra-arterial catheter reperfusion. It has different names. Endovascular therapy, mechanical endovascular retrieval, MER therapy, you'll hear all these things. But these are procedures that are performed by neurointerventional physicians. So these are neurologists who have a special training to perform a procedure where you actually go in through the groin, or we can go through radial approach now too, but you go up into the brain and you actually pull that blood clot out of the artery in the brain to stop that ischemic stroke. So again, it's a line reperfusion of that area. But the tools to get into those arteries are kind of big. They're not, if you saw them, you would go, really, Lizzie? They're literally smaller than the tip of my pinky, but in a brain, that's big, okay? And so we have to make sure that it's a larger vessel occlusion. So in other words, guys, the big strokes are the ones who can get this procedure. We also have small vessel occlusion, which are more of the smaller strokes, more of the minor symptoms, and we can't get into those little arteries. Those tools could actually blow that artery. And so we don't want to, again, cause harm. We're here to do good. And so those are things that we do assess the patients for. So when patients come in, our protocol across Premier Health is we do a CAT scan, and we also do a CAT scan angiogram. So we look at the arteries within the brain too. The CAT scan we do just to detect if there's a hemorrhagic stroke or not. The CT can show us bleeding within 2 minutes, and I can see it right away on the screen. It just takes 2 minutes to get the patient on the table and run the CT scanner, okay? But for this, we have to actually look at the arteries. So the angiogram can show us that, and it can show us if there's a clot in one of the larger arteries in the brain, which again, helps us with our time. The time frame around this is 24 hours from symptom onset, which is wonderful. It moved from when I started in this role, it was only 6 hours. And they did more research. So now we moved that out to 24. So for people who are having a larger stroke, even though they may not get that tenecteplase, the drug that I talked about, but they typically come in time, though, to still get the endovascular reperfusion. So somehow we can still get them some treatment, which is a blessing for those folks, because large strokes are the ones that leave the big deficits. So here's a picture. So these two here on the left are strokes. The clot is right there. You see, clot's right there, because you can see the contrast moving through the brain, which is also where the blood flow would go. So we've gone in and we've pulled these clots out. These are big arteries here in the brain. This internal carotid here, they branch off to a middle cerebral artery, which goes this way, right? And look, we've restored the blood flow. Look how much of that brain, guys, wasn't getting oxygenated blood. This person would have had huge deficits. Same thing here. All of that area in that red circle was without oxygenated blood. Okay. Are you at risk? So I want you guys to know the risk factors. So you can have modifiable and non-modifiable risk factors. So of course, modifiable, these are things you can do something about. This is why stroke is preventable. 80% of strokes can be prevented. So high blood pressure, remember I said, high blood pressure or hypertension is what we call it, is the #1 risk factor for stroke. Smoking, so smoking cessation is important. Diabetes, managing your blood sugar. Carotid artery disease is a big one. I would say that we really don't do an excellent job from, I would say, annual physicals of looking at the carotids, but if your provider is doing a good, thorough assessment, they should be listening to your carotids. So like when they listen to your heart and your lungs, they should be listening to your neck here, your carotids right here. To listen for what we call bruit, it's like a torturous sound, and that can actually, we can hear if there's any atherosclerosis or plaque buildup in there. So make sure that they're listening and paying attention to your carotid arteries, guys, when you go to get your annual physicals, okay? All right, atrial fibrillation we talked about earlier, high cholesterol, obesity, and I like to kind of clump obesity and sedentary lifestyle together. Hormone replacement therapy we talked about, and one that I think always surprises people is obstructive sleep apnea. OSA is what we call it, and it is a risk factor for heart disease. I think we probably know by now, I think it's been on TV quite a bit, that a lack of good sleep and restful sleep and a good 6 to 8 hours a night actually increases your risk factor for high blood pressure and diabetes and all these other things, right? You don't manage your stress as well. I personally, this is my opinion, this is not necessarily a professional opinion, I guess, but I feel like stress is the culprit to all conditions and diseases. Good coping skills, there's just nothing better than having good coping skills. Okay, so those types of things. Again, you can manage these, but you can't do it if you don't know about it. And so I really am big on doing a Know Your Numbers campaign, and we actually do that with our employees across Premier. We have a whole healthy living program because guess what? We want people healthy. We want people at work. We need to be able to take care of you all out in the community. And so we really push ourselves to be healthy and healthier. So make sure that you're taking your meds as prescribed, that you're talking to your doctor, that if you have high blood pressure and diabetes, that you're checking your numbers at home. You can get a little blood pressure cuff from the pharmacies. Make sure you have a glucometer and you're checking your blood sugar. And actually nowadays, people have continuous glucose monitors or CGMs. You see the people with the little things on their arms and they can just put their phone up to it and read it. It's really nice. Those are lovely. We've actually been using them in the hospital, started during COVID, to help cut down on our exposure. And we've been allowed to continue to use them. And then these are the things we can do nothing about. Age is age. As we all get older, our organs age, our arteries get older, they become less pliable. All of us are going to get some plaque buildup. It's just about how much, right? That's why we still have to be good stewards over our diet and exercise and doing these things to try to minimalize the things that are not modifiable. Gender. Women, we're at higher risk for stroke for the reasons that we discussed earlier, as well as we're living longer than men. So the longer you live, right, the more chance you have of getting things. And then race. So we find that African Americans, Native Americans, and Asian population are at increased risk for stroke. And then a prior history of stroke. So if you've had a stroke, guess what? That now becomes a risk factor for another stroke. So again, prevention is the best thing you can do. Right. So control your modifiable risk factors. That's what you can do. And it's up to you to decide what changes you're going to make. We all have control. So I just ask you to please take good care of yourselves and your loved ones. Talk to your family members. Teach your grandchildren. Be fast. Kids are really great at all of this. They're phenomenal at sticking to the point. They're very literal about things, right? And that's a good thing because they'll say, wait a minute, something's wrong with grandma, mama, or papa, right? Pop, pop, that's my husband's name. Pop, pop. So you want to be sure that you teach these things to your loved ones so that they can recognize the signs and symptoms, call 911, and please get you into that emergency room. Quit smoking. I'm screaming it, right? I'm the only one in my family that does not smoke. I have been on the Stop Smoking campaign, guys, since I was in the 5th grade. And they just won't listen to me. I was like, wow, okay, really? And then my sister says every day, I really need to stop smoking. Yeah, you think? Yes, please, stop smoking, I tell her. And I'm the baby, by the way, so can you tell? You can tell, right? I've been on the Stop Smoking campaign. And it all happened, I was in class. They were, back in the day, they used to show, reel-to-reels in class. And it was a smoking thing. They were educating us on not smoking. And they showed lungs and lung slices of a smoker. And I about freaked out and fell out my chair because I thought that's how my mom and dad's lungs look. Because they were both smokers, God rest their souls. And I thought, oh my God, I've got to save my parents. So it became a true campaign. I went home and I got all these stop smoking magnets and put them all around the refrigerator in the kitchen. My parents just look at it and go, okay, open the fridge. But hey, so I just really ask. But if you stop smoking, this is what happens, guys. Within 20 minutes, your blood pressure, your pulse, the temperatures in your hands and feet return to normal. 24 hours, your chance of a heart attack decreases. It's just that fast. 2 weeks to 3 months, your lung capacity improves. You can breathe better and take a nice, big, deep breath. Within 1 year, your risk of heart disease cut in half. In a year, in half. 2 years, your heart attack risk drops down to normal, which means you're really no longer at risk. And then within 5 years, your stroke risk is reduced. So it's really important. So talk to your providers. We have drugs out there that can help with, and it's not just all the nicotine replacement stuff. There's actually some prescribed medications that we can also give that can help reduce, that desire to smoke, So yeah, talk to your doctor. Go to a smoking cessation class. We do have them across Premier Health. And I'm sure Kettering has to have some too. Or even just out in the community, I'm sure there has to be some classes. So, stick with people who are in the fight with you. It helps with the motivation. All right. Again, know your numbers. Monitor your blood pressure. Right now, it really should be less than 120 over 80. Your blood sugar, normal is 70 to 120. Cholesterol, total cholesterol should be less than 200. HDL is the good cholesterol, so we want that up higher, above 40. Janelle and I just did some stroke screenings, and there were a few people there, their HDL was above 100. I couldn't believe it. I was like, what are you doing? I need to tell everybody what you're doing. They're like, nothing. I'm like, good DNA, you know? They're blessed people, but this actually fights heart disease. So the higher this number is, the better. LDL is what we look at mostly, guys, in AMI and stroke world. Best is less than 70, and we definitely want it below 100. And your triglycerides should be less than 150. So please read your labels, your food labels. It'll tell you like saturated fats, how much sugars and, you know, in the foods you're taking in. Try to bake and not fry or grill, you know, broil. Those are always better modes of cooking to help cut down on your saturated fats and your cholesterol levels. But this, guys, is just showing you a schematic of how, as providers, we look at blood pressure and how, like our guidelines to how to treat. So if you have a mild hypertension, this is pre-hypertension, we may just monitor you here. We'll probably say cut down on your sodium, you know, watch it through diet, start exercising. When you get into here, we're going to get you on meds, okay? And so we usually start with a diuretic first, so a water pill, because blood pressure also can be caused by increased fluid on the body. It puts a lot of strain and stress on the heart to pump. And so the heart has to pump against that water pressure. And so the pressure goes up to try to push the blood flow through. Does that make sense? Could you visualize that a little bit? And so we try to start with lowering the fluid levels in the body before we'll add all the other types of antihypertensive drugs onto the patient. Now, but if you're around this range, though, we're probably going to put you on quite a few right out the gate. Okay, this is hypertensive urgency. Actually, blood pressures this high mimic stroke. I have patients that come into the ER sometimes and they're having really strong stroke symptoms. And the difference is that their blood pressure is higher than stroke parameter. Because we do allow the blood pressure to stay high for the first 24 hours in a stroke patient because we're trying to perfuse the brain. And so we have to bring it down some even to get within stroke parameters. And we notice that when we bring the blood pressure down, their symptoms start to resolve. If they're having a stroke, the symptoms will not resolve no matter how much I lower that blood pressure. And typically, if I lower it too fast, or lower it too low, the stroke symptoms get stronger. And I can actually cause that stroke to extend and get worse. So it's a fine line, right? And so those types of things, you want to be sure that you're definitely treating your blood pressure. And I find that diabetes and hypertension tend to come together because one kind of damages arteries. It's kind of this cycle that goes on. Then the other one starts to damage arteries. And they kind of feed and play off each other, I find. And we kind of already talked about diet, but yes, choose baked, eat your fruits and veggies. If you're diabetic, please follow your diabetic diet. And exercise. We just did our stroke update for Premier. We do one every year for providers. And so Dr. Terry, who's our medical director for stroke at Miami Valley Hospital, he was just saying that really research is showing nowadays that the best thing you can do for prevention of stroke and heart disease is to get moving. Exercise. They're saying it is the best thing you can do for your health, cardiovascular health, gets your blood flow going, you know, keeps your heart healthy, your brain healthy. Research has shown that it fights dementia, it fights Alzheimer's, it fights brain disease. So 10,000 steps daily or at least 30 minutes 3 to 4 times a week. And it doesn't have to be like running a marathon, okay? I'm talking a brisk little walk around the block a few times. Go walk at the local gym. Get a membership. And that's nice too, because then you can fellowship with other people. Nothing better than fellowship in my world. Okay? All right. Take your meds. I already said this, but we're going to say it again. Your blood pressure meds, your diabetic meds, cholesterol medications, anti-anxiety meds. Remember I talked about stress and anxiety? It's not a stigma, guys, and it is okay. There is nothing wrong with needing a little bit of help if your anxiety is super high and uncontrollable. If your stress levels are so high that it is causing you distress in your life, please get a referral to a therapist. If you have insurance, look at who's covered on your insurance plan. Some insurances, like ours, offers free sessions. So please take advantage of that. Personally, I think every person on earth could use therapy. Just helps to talk some stuff out, get it off your chest sometimes, right? And with the person who's trained, right? And how to help you siphon through all of these feelings and emotions and things like that. And if you need a little bit of help, that's fine. Doesn't mean anything's wrong with you. And you don't have to stay on the meds forever. It could be just temporary to help you get through the rough patch. And then your anticoagulants, this is what we give to our atrial fibrillation patients we talked about earlier, and antiplatelets. So all stroke patients who've had a stroke will be on antiplatelets. That's aspirin and Plavix. We will put you on that for the first 21, maybe 90 days, depending on where your stroke was and how bad the atherosclerosis or plaque buildup is in the artery. Typically, you come off the Plavix after that 21 or 90 days, and you stay on the aspirin. Remember, the signs and symptoms of stroke. What did I tell you guys to remember? Be fast. Remember your be fast. Remember when to call 911. Remember to take your medications as prescribed by your doctor. Know your personal risk factors and know your numbers for stroke risk. And then have regular follow-up appointments with your doctors and your providers. It could be an advanced practice provider like myself. And get moving. Dancing works too, guys. Go take some line dance classes. That's what me and my best friend go do. And it's a lot of fun. We really laugh a lot. And there's a lot of older people in there with us, man. We just have a blast with those older ladies and guys. There goes the rain. It's back. Just in time. And these are my resources. So if you guys ever want to know, there's a lot of resources out there. American Heart, American Stroke Association is our #1 resource across the globe. But we also have National Stroke Association. Actually, American Heart and National Stroke kind of combined about a couple years ago, the Stroke Network. And then, of course, we have a stroke site at Atrial Medical Center and Premier Health. So you can also go on our intranet page, and we have a lot of information out there about stroke and stroke prevention. And that's that. Thank you.